Now's the time to finally realize we the people must make some choices. If we want single-payer health care, now's the time to raise our voices.
Welcome to the monthly meeting of Physicians for a National Health Program, Washington Chapter. My name is Sherry Weinberg. Yes, it says Sarah, that's my formal name, but I'm called Sherry. And I'm the president of this chapter. I'm a retired pediatrician, and I've been a member of PNHPWA since the late 1980s. We welcome you here to the land of the Salish, the Snoqualmie, and a few other tribes in this area who were here for thousands of years before white people arrived. So we acknowledge that. I'm on Mercer Island, which is an island in Lake Washington. Sounds very romantic, but it's 10 minutes from downtown Seattle, and I-90 goes across it. However, back in the day, they say the Snoqualmie had a couple of villages on the island at the time, but white people were scared to come here, considered the island haunted. Who's next?
I've just got some clay announcements to make. Regarding our website, we're having that redesigned and it's going to be much more functional. And we're hoping to get that going before our next monthly meeting in November. And we're pretty close to it. We're just getting some more photographs and stuff. And we've got a super expert guy who's doing it for us, Simon Hutton, who also, I think, did it for One Payer States and some other places in Oregon. And he's really nice to work with. We met with him a couple days ago, and hopefully we're close enough that we can put it up before our next monthly meeting, and there'll be some changes that'll be added after that. But it's going to be pretty functional, and it's looking good. Next monthly meeting will be November 19th, and that'll be a report back from the PNHP annual meeting in Washington, D.C., which is at November 1st to 3rd. And we expect to have a bunch of students going, and I know Hugh and I are going, and I'm not sure who else might be going, but anyway, we'll be represented there. Our December 17th monthly meeting, we've got Mimi Sared, who's an American emergency room doctor who's been in Gaza for several times helping out there. So she's going to report on, quote, Gaza's healthcare nightmare. So we'll have her online, and I think that'll be pretty illuminating. We've got the No Kings rally coming up this Saturday in Seattle, the one in Seattle, and there's probably one going on in Spokane too, Chris. Hugh and I are going to be at that, and I'm hoping some other people will join us at the Seattle Center, and we're going to be carrying our banner with this on it. I think there's going to be a march from there. I'm not sure where it's going, but the last time there was something like this, there was thousands of, I think, what do we have? 10, 20,000 people marching through the streets of Seattle. So that was the biggest one I've ever seen. And this one's probably going to be bigger than that one. So it'll be a pretty amazing scene there. Hopefully you can come and help Hugh and I carry the banner. It's not that heavy. And stop the kings. No, we got to get rid of the kings. Okay, so that's about what I've got to say. So Hugh?
So it's a real pleasure to introduce our speaker tonight, Suzanne. Gosh, we go back, what? I don't know. We're trying to figure out 10, 15 years maybe. But she was one of our invited annual meeting speakers once upon a time. And she's also presented about 3 years ago at a joint meeting with Basara down at Union Hall, Washington State Federation of Workers. Suzanne is an author and an activist and a lecturer who started doing some investigative journalism on the nursing profession and wrote a couple books about nursing. And then she got interested in the VA system and has written several excellent books. Her latest book being entitled Our Veterans, subtitled Winners, Losers, Friends, and Enemies on the New Terrain of Veterans Affairs. And in the New York Times book review, they quote, "This chilling account explores the physical, economic, and psychological consequences of military service on veteran health and takes a critical look at the many players involved in shaping veteran life in the United States." Her previous book was called Wounds of War: How the VA Delivers Health Care. And I can't read my writing here.
Health, healing, and hope to the nation's veterans.
Thank you, Suzanne. And she described it in that first book about the VA, how the VA does a better job than the private sector institutions offering primary and tertiary care and geriatric care, mental health services, and wraparound home care services, really to meet the myriad needs of the veterans. And I think, Suzanne, you did that work after you spent some time at the San Francisco VA. Was
Yeah, I basically spent 5 years all over the country at VAs all over the country.
yeah.
So
And that she got bit by the California bug, or she wanted to move from Massachusetts to California to be closer to her family, particularly her grandkids. So it's a real pleasure, Suzanne, to have you here and to be our speaker tonight.
thank you. Let me just tell you a little bit about how I got into this, and then if I could share the screen. I'll zero in on why I'm here tonight. So I've been writing about healthcare for almost, I don't know, since 1986. And I've mostly wrote about nurses. I've written 23 books and I don't know how many articles. I've been a journalist since 1971. And I was very interested I mostly wrote about non-physician healthcare workers, professionals, and other workers. I wrote a play with a playwright called Bedside Manners, where I looked at doctor-nurse relationships, and it was presented in, I don't know, over 100 venues, medical schools, nursing schools. Lucian Lee, my wonderful friend who died, had me do the play at the National Patient Safety Forum. It was really fun. And I edited a book series on healthcare for Cornell University Press for 17 years. And as part of that effort, I decided in 2014-ish, because I'd been in some touch with the VA, to look at to write a book about VA healthcare, because I was very curious about how a national health system worked. You know, what does a national health system look like in the United States? And I spent 5 years going to VAs all over the country and was just sort of knocked out at the quality of care there and also at the specificity of the VA patient population and how difficult it is to take care of them and what specific problems they have. And also at how the VA did a whole bunch of things that the American healthcare system doesn't do well, which is maybe not a very high bar, but I mean, it's hardly does anything well anymore, but, primary care, mental health care. And I really view the VA as America's only healthcare system. I think we have a dysfunctional medical treatment system, and everything says healthcare, but healthcare and medicine, as everybody on this call knows, are really different. And the VA is actually a healthcare system. It's also an occupational healthcare system. And I think it's very important to sort of recognize that, because it's probably the biggest occupational medicine / healthcare system in the world. And as you know very well, medicine doesn't do occupational medicine very well either in this country. So it's a very interesting system. I wish I could get the kind of care that veterans have, because none of us will ever experience VA care, the kind of care that vets get when it's at its best and well-funded and well-staffed. And I wrote this book. I'm a journalist. Some people have accused me of being a sociologist. And I hang out and I watch how things work. And, if they tell me at the VA that they do healthcare well, it's like, congratulations, but I'd like to see it. And I did. I mean, I had sort of carte blanche in the whole system. I cooked this book up with my friend, old family friend, Bernie Sanders, who was at that point chair of the Senate Veterans Affairs Committee and very involved in veteran healthcare and at the time, and also with a guy in VA, a deputy undersecretary for patient care services in VA. And I really, I mean, I could only have done this book then. They wouldn't let me near VA now or in Trump 1, or even Biden. Biden wouldn't have let me in. But I had, Shinseki, Eric Shinseki, the secretary. I mean, I had like a cart, I was allowed in, and I actually even had my own PR guy in VA central office who I would call and say, I want to go to Dallas, make it happen. And who should I talk to? And I did that all over the country. I mean, I could only do it at so many places because VA operates 170 hospitals and 1,200 sites of care. So, there's only me. And, I became convinced at the time that I was doing this, that this is a model for healthcare for our country. I mean, it's an American model. You don't have to go to Scandinavia or the UK, and certainly not Canada, to find a model of a socialized medicine system. It's right here around the corner. And because it works so well, and the studies confirm this over and over and over again, they're trying to kill it because the ideologues who hate government don't want a government program that works. And they also don't want, taxpayer money spent on a public good. They want that money to go to the private sector. And they have largely succeeded, thanks to the help of many Democrats, to create programs that outsource a lot of care to the private sector. And they promise veterans that they will find, as Avik Roy, who was head of one of the Koch brothers fundies and head of, I can't remember if it's Center for American Prosperity, I basically said veterans should enjoy all the vast array of choices that other Americans enjoy. And of course, we know that that's not true. Increasingly, they, whatever choices they have, they don't have an array of them, and they certainly don't enjoy them. They have convinced, many Democrats to vote for legislation that basically outsources more and more care to the private sector through, first it was the Choice Act, and then it was this VA Mission Act of 2018. And now we have accelerated privatization under Trump. He's, as you know, cut VA research, VA teaching. I'm sure people know, but maybe you don't, that, the VA has sort of 4 missions, not just providing clinical care to veterans, but it teaches the majority of American physicians in training, the majority of nurses, vast majority of psychologists, OTs, PTs, et cetera. I mean, it plays a pivotal role in the American healthcare training system. It is the second largest research powerhouse after the NIH, and does not only funds but conducts all kind of research, and obviously a lot of it's on veterans. Some of the stuff that it researches nobody else would touch, like, and one of the things that they've done when they in their attack on science is cancel a lot of contracts of people who are on these short-term contracts, renewable contracts, that are doing major research. And for example, one of the research studies that it was in jeopardy was a study of a generic medication that their hypothesis would help avoid, for people with severe renal disease, would help avoid dialysis or transplant. And this is the kind of research only the VA would would do because it's a generic, there's no money in this, right? I mean, there's no money to be made if they find out that this generic works in that regard. And so the final mission that the VA, the fourth mission is emergency response to floods, wildfires, hurricanes, tornadoes, etc. And all of that is invisible to many people in Washington, as is the function. Many of the things the VA does. I mean, the National Centers for PTSD are world renowned in dealing with PTSD and serve not just veterans, but first responders and, people with trauma all over the place, all over the world. There's just so many programs that they do. And as I said, it's a healthcare system. They deal with employment issues, legal issues, integrated mental health and primary care and so forth. So they're attacking, in my view, the model of care that we should all be fighting for. I mean, I would be happy if we got Medicare for all, but Medicare is a payer, not a provider, and VA is a payer and a provider. And they want to turn it into just a payer. And so one of the things that brings me to you tonight is we at VHPI, so I helped found something called Veterans Healthcare Policy Institute, that is really very small, just a few people. Hugh is on our advisory board and has been a huge supporter and helper. And one of the things we're the only kind of think tank that really looks at veterans healthcare. I mean, it's kind of incredible that there isn't, such a thing. There we don't have more competition, but we are really the only group that looks at veterans healthcare and fights for the VA. I mean, tragically, the veteran service organizations like the VFW, the Disabled American Veterans, the American Legion, they have been so cowed by the fear of not having access in DC, which the Republicans, of course, play on, that they've been very ineffective in any kind of response to either Trump 1 or Trump 2, and in fact have been big supporters of the outsourcing of veteran care to the private sector, because they, can go to their members and say, look, we've gotten you more choice. We've gotten you, you can go to CVS now or whatever, to a Minute Clinic. Isn't that wonderful? So in the process of fighting privatization, I decided about 8 months ago, that I wanted to really look at the capacity of private sector healthcare providers on a state-by-state basis to handle an influx of veterans. And so I'm not a statistician and I'm not this kind of a researcher. I'm a narrative journalist and occasionally an investigative journalist. I don't mind databases, but I really felt that it had to be done because there was this narrative, this myth, this claim out there that, well, why couldn't you just send these people across the street to the hospital across the street? And they could get good care. Well, first of all, as you as physicians know, to whoever is a physician or a nurse or on this call, a patient is not a patient is not a patient, and a doctor is not a doctor is not a doctor. And in order to take care of veterans, you have to know what they did in the military, and then you have to know the risks of that occupation. And then you have to know what are the exposures and what are the diseases or conditions that, accompany those exposures. Then you have to know what to do about that. So to give you a very good example, a woman I know who I just featured in an article that I did for the American Prospect on the impact of VA cuts on women's health, because the VA has established a very effective model of care for women veterans. 1 in 3 of them have had military sexual trauma, and they don't like men, and they don't want to hang out with men. And so I did this article, and I interviewed for the article a woman named Kylan Hunter, who is the new CEO of the Iraq and Afghanistan Veterans of America. And Kai was a helicopter pilot in Iraq. And it turns out that one of the risks for helicopter pilots or aviators of any kind is ocular melanoma, which I had never heard of. You may have heard of it. Obviously, anyone's physician. And ocular melanoma is not very common, particularly in, people her age. She's like 40. And no one in the private sector would screen a patient like her for ocular melanoma if they didn't know she was an aviator, and that, aviators are prone to get ocular melanoma. And basically, she goes to the VA, they know she's an aviator, and it's a routine screening, and they catch it very early. Apparently, it is asymptomatic and, not like a melanoma on your foot, or your arm or your face. Well, if she'd gone to the private sector and not the VA, she could be dead in God knows how many years, because ocular melanoma, if it, metastasizes, has a 5-year survival rate of 15%. So it's just appalling, what they're doing, because physicians never, it's not in an H&P, the question, did you ever serve in the military? It's not a question that is ever asked of people. I have never been asked that question. I could have been a nurse in Vietnam. My husband has never been asked that question. He could have served in the military, been drafted, whatever. So you have, people going out into the private sector where they're not required to do any trainings on any exposures, on suicide prevention, on any of the mental health conditions that veterans have. My friend Kayla Williams, who was in Iraq and had military sexual trauma, was assaulted, went to a private sector psychologist and said, the private sector psychologist had said, "What brings you here?" And she said, "Well, there's this and there's that and there's MST." And the psychologist said, "What's MST?" And, you can't fault the psychologist for not knowing what MST is. I mean, I probably, if I hadn't been doing this work for 15 years, I wouldn't know what it is either. I mean, but it's really appalling. I mean, I've actually been to some PNHP meetings where young residents would say, "Well, I'd be happy to do my bit for veterans. I mean, a patient's a patient's a patient." And, they don't know that, no, actually, that's not really correct. These people have particular problems. But so there's a competence issue, right? But then there's also a capacity issue. And so that's what I spent 5 months doing, and why I'm kind of talking to you today, is that I decided that I wanted to look state by state and see, how many veterans are there in each state? Male, female, what's the percentage? How many are over 65? What the income level is? How many facilities the VA has? What would happen in, a state like Washington or California or wherever, if you had this massive influx of veterans into the private sector system? Are there enough primary care providers? Are there enough mental health providers? Are there enough hospitals, et cetera, to take care of them? And so what I found, I mean, we all know this data on a national basis, but I was really just stunned by the shit show that healthcare is on this kind of granular level for every state. And the, clear messages that, and that this is why I think this report, which is very long and detailed. I mean, one could have written 20 pages per state. One could have probably written 50 or 100, but I only did 2 per state because there was just me. It is staggering, particularly in rural areas, but even in urban areas, what the lack of care, the no care there is. And the report is called The False Promise of VA Privatization, a 50-state reality check of private sector capacity. And as I said before, the VA delivers, superior care at lower cost, and I've outlined some of the ways the Trump administration is trying to kill it. But the privatizers insist, that there's just thousands of competent providers just kind of waiting with open arms to take care of these patients, who, by the way, are way more complex than most civilian sector patients. They have higher suicide rates. 41% of them have serious mental health diagnoses. And as Tom Insel, when he left the NIMH, said, of America's 780,000 mental health providers, very few of them actually know how to take care of serious mental illness, right? And of course, we have a mental health system in tatters, highest suicide rates in the industrialized world, fewer psychiatric beds, et cetera. And so I just kind of wanted to look at the facts and critical shortages of physicians, primary care providers, mental health providers, et cetera. So, I mean, we know the facts: highest death rates for avoidable mortality, fewer physician visits than patients in industrialized countries, lowest rate of practicing physicians, and few hospital beds. This was really interesting, that right now, the veterans in these 10 states, I call them the terrible 10, are largely sheltered veterans in the VA. And that's usually about half the veterans in any state are eligible to be enrolled in the VA, because not every veteran is covered by the VA. You have to have a proven service-connected disability and/or low income, and/or have to have served in a combat zone in post 9/11. So, in all these states, for example, you would be feeding veterans from a system that is documented to have superior care to the private sector into healthcare systems that are just crumbling, right? I mean, just non-existent. They're terrible. We have 83 million people living in areas without enough healthcare providers, and 79 million live in areas with shortages of primary care providers. That's, you have 248 million adults in America. So what is it? I don't know what percentage of it's close to a third of the population has difficulty getting primary care providers. I mean, before I found my primary care provider, after my guy left practice, it was horrible. I know I have a friend who just got a job at UCSF. He can't get a primary care provider at UCSF because the practices are closed to new patients, including doctors who work at UCSF. I mean, it's would be a bad Saturday Night Live skit if it weren't so tragic. Mental health, 55% of American counties have no psychiatrist, psychologist, or social worker. 55% of psychiatrists accepts insurance. Only 55% of psychiatrists accept insurance. A third of psychologists don't accept insurance, and 6 out of 10 psychologists aren't accepting new patients. So, and this is in urban and rural areas. Mental health, I mean, almost 47% of the adult population lives in a mental health professional shortage area, rural counties. 81% of rural counties don't have a single psychiatric nurse practitioner, and 65% don't have a single psychiatrist. Hospital closures, and all of this, by the way, is pre big beautiful bill, right? So all of this is getting way worse. We have 300 hospitals closed nationally since 2010. Rural hospital closures, sorry. And it was very interesting to me that one of the biggest things that I found out was that many rural hospitals have closed services, even if they haven't closed. Among the key services they've closed are chemotherapy and obstetrical services. And the site, I didn't include the citations here, they're all in the report. Modern healthcare, no, not modern healthcare. Health Affairs just did a big article about the closures in urban and rural areas of obstetrical services. So the great irony of they don't want you to have an abortion, they want you to have a kid, is there's no increasingly fewer places where you can get prenatal care, labor and deliver your baby, or have, postnatal care, follow-up care. This is Washington State, your state. These are, I don't know how many of you know kind of the Rural Health Information Hub, but it's just a great resource. And they have maps of everything. They were kind enough to let me use these maps. So this is Washington State primary care. Look at it. The dark blue is severe shortages. That means there's almost no one there. And the lighter blue is partial shortages. I mean, this is where they want to send veterans. I mean, this is where non-veterans are struggling to get care, and there's no care there. Washington, it's interesting. The only VA is actually the only healthcare system that actually calculates and publishes wait times. The only way, I mean, obviously many systems know what their wait times are, but they don't tell you. The only group that studies wait times occasionally, it was called Merritt Hawkins, and now it's changed to AMN. And they did a study in 2022, and they did another one in 2025. And Seattle was, in fact, they do it for 15 metropolitan areas for cardiology, family practice, gastroenterology, dermatology. It's five subspecialties. And in Seattle, the average wait time was for cardiology, family practice, and GI was 62, 51, and 48 days. The longest wait time was 165 days. So that's to see a cardiologist, 207 days to see a family practice physician, and to see a GI was 126 days. And the average wait time in the VA is probably 15 to 30 days. So, I mean, my husband in the Bay Area in Berkeley, the East Bay, he tried to get a pulmonology appointment for quite a serious cough and chest problem. He was given an appointment 4 months in the future. And then 2 weeks before that appointment, he was told the pulmonologist left the practice. You have to wait another 5 months. So it's 9-month wait. It's just, unbelievable. You all know, I know. I tried to get an appointment for a friend of mine who lives in Tacoma. I think I talked to Hugh about trying to find a psychologist for him. And I think I finally got the guy, and he's like, oh, that'll be 4 months, maybe. We actually found a psychologist in California who would deal with this particular problem and would do telehealth, but she could not do telehealth with someone in Washington State because she wasn't board certified, she wasn't, licensed in Washington State and California. They're beginning to change this for psychology in a number of states, but the VA is really special in that because it's a federal system. A psychologist in California can do therapy with a with a patient in Boston because it's a federal system. And ditto, an oncologist or, anybody in the VA, if it's appropriate, can do a telehealth visit with anybody in any other state because it's federal and you're working under a federal license. And this is not true in the private sector at all. So it's a huge, the VA has a huge telehealth. It was one of the big leaders in telehealth, but it also has that huge advantage. This is Washington State mental health shortages. So let's just go back and look at physician PCP. It's even worse, right? For mental health. You have 1, 2, 3, 4, 5, 6 counties have partial shortages and the rest are severe. So that, where are you gonna, and if you're feeding veterans into an overburdened system, that's bad for the doctors, it's bad for the nurses, it's bad for the patients because, like in San Francisco, the VA takes care of 100,000 or more patients, right, in San Francisco VA. So these patients aren't going to UCSF ER or Sutter or PCMP. They are going to the VA. So you are unburdening an overburdened emergency room system, et cetera. And, this is adding patients into overburdened systems. If you start, the more patients you outsource, the more of the American public and political representatives are going to say, well, if they're all going to the private sector, why should you pay the same fixed and labor costs for doctors and nurses and facilities that they're not using? Makes no sense, right? Now in Washington, as I said, you have 39 counties, 32 have severe and 7 partial shortages. And again, even when you have a different map and you see a little bit of very light blue, which you don't see in Washington State, you have to recognize that, a third of psychologists and 45% of psychiatrists don't take insurance of any kind. In California, in the Bay Area, you cannot find a psychologist or social worker who does cognitive behavioral therapy and will take insurance. They just don't exist. And that's, of course, an increasingly popular modality, but for veterans, it makes a big difference because CBT is one of the gold standard treatments for PTSD, for insomnia, and so forth. Washington ranks number 10 in the nation for lack of mental health care providers. About 28.2% or 2.2 million people of the state's population are underserved and can't find adequate mental health treatment. And according to another report, Washington residents don't get treatment for a variety of mental health conditions and are at higher risk for suicide and homelessness. Then Washington hospital shortages. You haven't had a lot of hospital closings, but not yet. But 67% of Washington's hospitals have lost some services. 40% are at risk of closing and 13% are at immediate risk. And 21 to 30% have stopped offering OB services. And again, all of these stats on rural hospitals and even urban hospitals are about to get way worse because of the Trump cuts to Medicaid, ACA, and academic healthcare centers. Rural hospitals will lose 70 billion over the next 10 years, et cetera. I mean, I don't know what's happening in Washington State, but in San Francisco, in California, I mean, they're hiring freezes in all the hospitals. They're beginning to lay people off and services are closing and so forth. So, my message, I guess, is I hope people will find this useful, not only in the fight, against closures of VA facilities and services, but also just in the work that you're doing on a state basis, because the report that I did has a lot of data that people might find useful. And I mean, one of, I guess, my big messages to a lot of folks who are healthcare reformers is the VA has been pretty much an invisible healthcare system. People have not used it as a model for touting socialized medicine or Medicare for all, except on the right. And people have been pretty unconscious about the larger role the VA plays in the broader healthcare landscape. I mean, I'm always stunned by that. I was working with an author who proposed a book about medical assisted treatment for, addiction. And she kind of knew about VA, which is a leader in that. And she was, in her book that she proposed, she was looking at healthcare systems in Europe and, overseas that used MAT. And I said to her, but what about the VA? Like, it's kind of here, it's around the corner. And she was like, oh, the VA, oh, really? What an idea. It was like a stunning idea to her. I can't tell you how often I encounter that, people know about the VA and I don't know, they think it's for veterans. And so, what does it have to do with us? So I'm hoping that folks found this of interest and find the report useful. As I said, it's state by state, so it's got information on every single state. I have found it very useful in talking to legislators, not only about the VA, but about broader healthcare change. So I think that's all I have to say, and I'm looking forward to chatting with folks or answering any questions people might have.
So Hugh, do you want to run the Q&A? So I have a question. I know in the past you've been fighting the misinformation about how long it takes to get a veteran an appointment at a VA hospital and therefore open up private hospitals to VA people going there. And I think your, stance is that these other places that have very little idea about the needs of veterans, whereas those in the Veterans Hospital, the providers there, have been working there a long time and are really clued into what the problems are.
Well, yeah, I mean, look, it's sort of axiomatic. If 100% of your patients, I mean, it's a population health system. It's like a pediatric hospital, right? You wouldn't send a kid, I mean, a 5-year-old to an adult. I mean, unless you had to, unless there was nobody else. So, I mean, these veterans have all these exposures. I mean, I think if you think of it as an occupational medicine system, it really kind of, to me, that when Ken Kaiser, who helped create the modern VA, sort of said that to me, it was like a light bulb going off. It's like these people know, if you served in Vietnam, there's this thing called Agent Orange, and there's a whole bunch of things that happen if you were exposed to Agent Orange, or if you were exposed to combat, or if you were at Camp Lejeune and you drank the water, or if you're a woman or, and had military sexual trauma. And 100% of their patients are veterans. And it makes no sense for a doctor or nurse or NP or PA outside of the VA. The veterans we have 9 million veterans who are eligible for VA care right now. There's probably 11 million out of the 18 million that are eligible. So, but right now there's 9 million enrolled veterans. That's 3% of the American adult patient population. I'm using 248 million adults. 9 million is 3%. Women veterans, there's 600,000 of them. They represent 7% of the VA patient population. So there's 600,000 of them. That's 0.23%. It doesn't make sense for any doctor or NP or nurse or whatever to take the incredible amount of time it would take to learn about veteran specific conditions for 3% or 0.23% of their patients. I mean, and right now we know that doctors, I mean, there was that one study by Oxford and Hopkins and so forth, where they showed that, the average primary care provider, if they were to follow all national guidelines on preventive, acute, and follow-up care, they'd need 26.7 hours in the day. As we know, there's only 24, and people, I guess, need to go to the bathroom and sleep occasionally. So if you're that overburdened, I mean, in what universe for, 3 patients or 100 patients would you take the time to find out what the difference, about burn pit exposures and the difference between a cough and bronchiolitis, or, the multiple cancers, or, I mean, it's nuts. So in the VA, it makes sense because like they're only serving veterans.
But what are there privatizers within the upper echelon of the VA administration now? Because I know, or
Yeah,
is
of
the
course,
pressure?
like the very head of it, the secretary. I mean, they're all, I mean, they've killed the office of, they're all leaving. I mean, everybody who is anybody you would want to talk to or be seen by as a doctor. I mean, who's an administrator, they're all leaving. I mean, half of my sources and friends have taken, have taken deferred resignations. I mean, we're going to start posting on the VHPI website the data that the Office of Equity, which is no more, would post during Hispanic Month and Black Month and Indigenous Peoples Month, because they're not doing that because it shows that the VA pays attention to these particular cohorts of the veteran population and how much they help them.
So what's the hope for reversing this trend at the
Yeah,
upper?
well, I think that's the question. I mean, I'm excited because veterans are getting really pissed off. And, now they're going after their benefits. There were 2 horrendous stories in the Washington Post last week that I think were very much promoted by the Heritage Foundation Project 2025. And they want to, cut back, they're accusing, all of these people who have disabilities of being defrauding the government. And what's so bad about allergic rhinitis or tinnitus or eczema or military sexual trauma or PTSD, really, like migraines, I mean, how do we know you have migraines, Maybe Robert Card had migraines before he killed the 19 people in Lewiston, Maine, because, and I'm very heartened by the amount of veterans who voted for Trump, who thought that he was, I mean, we did a survey, not a survey, we did a Facebook campaign, VHPI, in 8 swing states around Project 2025 and what they were going to do. And we, targeted veterans. And it was very interesting because not a single one of the MAGA vets who responded to us said, these are great ideas. cutting benefits, cutting programs, privatizing. Nobody said that. They all said Trump would never do that to us. That's what they said. And now, guess what? Trump is. And some of them are realizing that. And it's the same thing with the rural health crisis, with you've seen the responses of folks to, Medicaid cuts and so forth, like, oh, I voted for Trump and how could he be taking away my Medicare? This is awful. And so I'm extremely heartened by the fact that at many VAs we're having rallies and protests, and there are people there who are like, voted for Trump, and they're out there. The Republicans can't go. They've been holding meetings all over the country, and they're being assaulted by non-veteran Republicans. Like, what are you doing to the veterans, to the VA? So this is a very ripe group for organizing because I'm sure there are many MAGA veteran voters who will follow the guy over into the abyss and jump out of the airplane into the Pacific Ocean with him. But there's many of them who the support is thin, and they're suddenly seeing that, wait a minute, he said he didn't know anything about this. He's attacking us. I mean, they've had big protests. Veterans have been arrested for protesting the ICE, going to ICE protests. And they've been where is it? And I can't remember where it was, but in some VA parking lots, the ICE people are using the VA parking lots, and people are not happy about this. And, we have the Federal Unionist Network that has started because the federal unions have been pretty moribund, and that's really great. So I think this is a huge opportunity, and I think veterans are very ripe for conversations and for, even discussing things like national health care and so forth. Because this is a very good moment for organizers and for people like us if we take advantage of it.
No doubt that when I think of the VA, it's it's the house of irony or ironies. I mean, one of the biggest causes of the inflection in healthcare costs has been the electronic medical record. If you
Yeah,
look back, it
right.
really took off in the early teens, and I was right in the middle of that fracas. And for a long time, the VA had the best, most comprehensive electronic medical record before anybody did. And the reason it was so good, even though it was clunky, and it took a while to learn, is because it was open source. It was a cooperative effort among very talented people, and it had no profit motive. But once the bean counters got in charge of that, well, the irony is now one of the least efficient corporations that make EMRs was given the VA contract.
Right, Cerner.
Cerner. And Chris, that's right in your community, right? The American Lake Project has been an absolute disaster.
Yeah, right.
And those of us that were involved with Cerner early, which I was when I was at Harborview, they were horrible. I
Yeah,
mean, they sold us etherware, and it would cost us 10 times as much money and 10 years to get it to be operational to where we thought it would do out of the box. I mean, that's just one of the ironies. And the other one is the VA system is great, it's wraparound, it's comprehensive, but any system that's underfunded is not going to thrive. And what the VA is like a crooked baseball stadium owner to be contemporary. Uh, if they make a bunch of home runs, well, just push the fence back. And if you look, and in the back of your book, there are what? Over a dozen different eligibility criteria to get you in the door to the VA. So many veterans have a bad taste in their mouth, A, because of the eligibility issues, and B, to the fact that the VA didn't pay very well. And lastly, most of the big VAs are associated intentionally with major medical universities, right? They're what they call Dean's Committee VAs, Seattle, LA, Chicago, San Francisco, etc. And one of the problems is the rural veterans are really in a mess. And one of the, John Tester, the senator from Montana, is on the committee for the VA, and he was one of
Not
the big,
anymore.
well,
He's
yeah, he
not
was, but he was the one who pushed a lot of this
right,
privatization
right,
because the distances in eastern Montana for a
right.
veteran to access a VA facility was really prohibitive. I mean, it's very, very difficult. So it's kind of a distillation of all of the other dysfunction in our healthcare arrangement that we have now, but it's going to go from horrible to abysmal when the chickens come home to roost, when they start defunding more of this stuff.
Well, I would, I guess, sort of semi disagree in the sense that I think the VA, even now, gives better health care than the private sector. And the studies sort of show that. I mean, I think the problem, I mean, I'm really glad you raised the problem of rural veterans because the problem with rural veterans is the problem of rural healthcare in America. And the reality that Tester never understood was that, in Montana, for example, 100, what is it, 150,000 square miles or
Oh,
more.
it's enormous, yeah.
I mean, it's huge. The rural healthcare problem is, and so 25% of veterans choose to live in rural areas or live in rural areas or rural and remote rural areas. And the problem with living in a rural area, when you choose to live in a rural area because you don't want to see people, is some of the people that you don't want to see are going to be doctors and nurses and OTs and cardiologists. And the reality is that they will have to drive because, I mean, you all know about the problem of rural healthcare. There is no way that you can take care of these rural areas without heavily subsidizing the system.
The only reason I think that a private practitioner in family medicine survives in a rural area, at least in our WAMI region, is that right around the corner from their private office is a federally funded
Qualified
healthcare
healthcare system.
center. It's the
Right.
welfare clinic basically, and
Right.
it's usually in the same small town. Um,
Well, and one of the biggest problems in dealing with veterans is these jerks like Tester and Jerry Moran in Kansas. They have no understanding. They don't understand anything about skill maintenance. I mean, how many patients, not just to support a practice, like to make a living, but to maintain your skills. And they somehow suggest to these veterans, oh, you can have a cabbage in Chico, you know, like California or Lassen County. I mean, really? Like, you don't want to have a cabbage in, I mean, if you live in some, like in California, for example, Kaiser, you can't enroll in Kaiser at all. You can't become a Kaiser patient if you live too far from a Kaiser facility. And if you live in, I don't know, if you live in Santa Rosa and you're in Kaiser, you're going to have to drive 2, 3 hours to get brain surgery or to get, cardiac surgery. I mean, they have a hub, right?
right.
As they should, because, and it's, this is what you have to explain to veterans. Like, this, it's the same, for the same reason that you can't get to an Office Depot to get your ink for your printer. You can't find a doctor because you live too far away from services. And so the VA has tried to deal with this by telehealth and by maintaining pathways to care. And the reality is in the Montana, whether you're a veteran or not, if you want specialty care, and many, because veterans are so sick and have so many comorbidities, they often need specialty care. They're going to have to drive. And they're going to have to drive 4 hours, whether it's to a VA or a private sector hospital.
Yeah.
The
Well,
problem is they're going to get better care at a VA hospital than a private sector hospital. But people who are in charge, who want the money to go to the private sector, not to enhance a public good, are lying to them.
anyone else have any other questions or comments? I had a great experience in the VA when I was a student. I mean, this is 1976, 77 in Omaha.
And the VA
But
that you had that experience at was not the VA that exists. I mean, the VA started changing in 1994.
right, right. And it was, I think it surely needed some improvement. I mean, one of the things, there's, I think, two things that are going to further impact the VA is one, it's been a way for internationally trained MDs to get a green card and stay in this country is because it's an underserved practice. And so, Suzanne, in this country right now, 25% of our practicing physicians are international medical graduates.
Yeah, it doesn't surprise me.
Do you know what it is in the VA?
What?
I don't, but I suspect it's higher.
I,
Um,
you know, I don't think so, but I can find out.
yeah, it
'Cause
would be interesting to see that statistic. Now, there's a lot of excellent people who are international graduates, and what they do is they gravitate at least initially towards underserved areas, which are either the inner city, the VA, or rural areas. I mean,
yeah,
um, uh, you know, Varghese, Abraham Varghese, the author of Cutting for
right,
Stone, is a prime example where
right.
he started his practice in rural Kentucky because he could get a green card and by practicing in that underserved area. He wrote a great book about the AIDS epidemic, which was his first book. But it's very interesting, and same thing with nurses. And so there has always been a little bit of a stigma of many, my brother being one of them, who's retired from the Marine Corps and the Army. Uh, they had bad experiences early on in the VA before they really tuned things up, and they won't go back. I mean, so I think it really does bring up a lot of problems that we have in the entire situation, and it's not a system in the US, it's a situation or an arrangement in that there's a horrible maldistribution. We don't train enough in our we don't train enough people in this country, both physicians and to a lesser extent nurses. Ronnie, you can attest to the fact that retail pharmacy is on the verge of collapse.
Yeah, you have your hand up, Ronnie, I think.
Did you? Oh,
Yeah,
it
I
is.
do. Did you address the veterans who are enrolling in Medicare Advantage programs and the money that's lost to the VA?
oh, sure. Yeah, no, I mean, um, I'm not an expert on that, but I mean, obviously it's terrible. And I mean, one of the things that is crazy in the VA system and the legislation is that, and one of the key things that, if we ever enter a better political environment, we should all be for is that, the VA can, if for non-service connected conditions, the VA can bill people's private insurance for that. And but it can't bill Medicare because the government is not allowed to bill the government. So one of the really, I think, ways to enhance the amount of people who could, be able to get into VA would be to allow veterans who have Medicare to pay, to essentially go to the VA under Medicare. But of course, the Medicare Advantage plans wouldn't like that. I mean, I think that, many of the people who would sign on to these Medicare veterans who would sign on to the Medicare Advantage would maybe be veterans who are not eligible for the VA. I mean, I don't know if you know, but most people think all vets are eligible for VA care and they're not. You have to
Right.
have a service-connected disability or a low income. It's kind of means tested. So, so there's about 7 to 9 million. I mean, there's probably 11 million people who are eligible, but 9 million are enrolled. So, and there's 18 million veterans. So there's about 9 million veterans who are not eligible or not in. So many of those veterans may be the ones that are, enrolling in these Medicare Advantage plans. If they could go to VA, they might not choose the Medicare Advantage plan. Really not an expert on this, Ronnie. I'm so sorry.
We know that Medicare Advantage spend an enormous amount of money on advertising
Right.
uh, and they're getting veterans.
Sure. Yeah.
Perhaps it's because services aren't available in a rural area, and the veteran thinks that Medicare Advantage program, or is
Yeah.
told that the Medicare Advantage program. So you're not aware of anyone that's really following up. It seems like there
Wait,
was a major article about it last year, and
I'm sorry, who wrote a major article?
it seems to me there was something out of Boston from Harvard.
Yeah, I should look into that more. I would be curious, who the veterans, I mean, I think it's definitely a very important area for exploration. And I think, I'd be curious to know if these are veterans who aren't eligible or haven't, been able to, the other thing is that there's a whole category, there's about 1 million vets. No, no, I take that back. About 600,000 veterans. The other, the other thing that determines your eligibility for VA care is your discharge status for the military. And there are about 600,000 plus veterans who are simply uneligible for any VA benefits because they have what's called an other than honorable discharge. It's very complicated to go into, but they've essentially been screwed by the military because they had PTSD or TBI or something and they acted out. And then the military didn't want to go through the complex process of a medical discharge, which means that you're undeployable for about a year while you're on the books. And so we explain this in our veterans. So there's a whole bunch of folks who would be, if they are Medicare eligible, um, who would be attracted to the Medicare Advantage plans who have OTH. So another way that you can deal with this is we need, some kind of legislation to allow the VA to take care of these people. It's a super scandal, this other than honorable discharge thing, super scandal.
So, if you are aware, and I see Marcia's hand up, but so if you are aware of data on that Medicare Advantage, or if it comes your way, the people here in the Northwest have been taking a lead on some of
Yes,
the damage
yeah,
that Medicare Advantage is
yeah,
doing. Certainly let us know, because it's it can it
right.
people can sign up,
No, I know, yeah.
without
And
any co-payments, and it's scary.
well, I mean, and this is another reason why I think folks like you guys have to, sort of defend the VA because, I mean, another way to get, I mean, my feeling is that every veteran should be allowed to get into VA, to VHA care, and I think so should their families and, dependents. And if you had I mean, imagine if you had, 18 million veterans experiencing a well-funded, well-staffed VA, socialized medicine, and then you added another 20, 40, 60 million because of their dependents, right? If they were allowed to get services at VA, you'd have a lot of people in a national health system.
Yeah. Marcia, you had a question or a comment?
Yes, thank you. Yes, I do. So I hate to be a naysayer, but every time I hear people talk about the veterans healthcare system, I hear negative comments from ordinary people. And given the barriers to getting care, for many veterans, if they haven't been in a combat zone, for example, and they this less than honorable discharge, I mean, I don't see the advantage to opening up a veterans healthcare type of system to more people, and I don't see it's possible. So I guess I don't understand the drift of this presentation.
I'm sorry, I guess I just don't understand your question. I mean, we have a healthcare system now that takes care of 9 million veterans and that the studies show delivers higher quality care at lower cost that's more accessible. Now, there's an attack on that system that has been funded by the Koch brothers and now the Heritage Foundation, so that a lot of the negative stories that you see are generated by, I mean, I'm not sure which ordinary people you're talking about, Marcy, who, I mean, if you talk to veterans, 92% of veterans are for improving, not privatizing the VA. So,
I mean, I don't want to rain on your parade, but it's just like it's contrary to what I've read in the media and just heard, like from stories. So
but can I just ask you
surprised.
a question? Can I ask you a question?
Yes.
So what have you heard from the media, the major media, about Medicare for all or national health care in other countries?
Well, they actually don't really report very accurately on that because they don't want to have it here. You
Right,
know,
but so
not much.
so do you believe their coverage of Medicare for all or national health care in other countries? Do you believe their reporting?
Well, they don't really cover it. So no, and I wouldn't believe it if they said it didn't work because
So
I,
why do you believe the coverage of the VA?
well, I don't know very much about it, but so this has been a very eye-opening evening for me. And so, but I just see the barriers being really high to getting more veterans covered. And
No,
oh,
I think that if I mean, I think you're right. I mean, I think there are barriers. There's many, probably less barriers to getting more veterans covered than to getting Medicare for all. I mean, we're not getting very much of anything now. So, I think people like us are in a long-term fight, and sadly, we're not going to be around that long term. But, I think that the message that I would give is very much the same sort of message of fighting against Medicare Advantage or we're up against the same. I mean, the negative press that you've seen since 2014 has been very carefully constructed to trash the VA because they don't want a government program that works, because they don't want any healthcare reform. I mean, they're using the VA and they want to destroy the VA because they're A, against government, and B, against any government program that works, and the VA works. And the studies show that VA delivers higher quality care, more conveniently located with fewer delays, than private sector care. And that's not something they like. So, this Washington Post story, you should look at that story, those two stories that the Washington Post just did about veteran benefits. It's almost Goebbels like, they take, it's like, Reagan's welfare queens. So, I mean, I think you're right that the public has been very negatively impacted about stories about, the VA, by very deliberately, by very well-funded. I mean, the Koch brothers pour $12 million a year into the Concerned Veterans for America. And the same people that they fund to trash the VA, they fund to trash Medicare for all, socialized medicine, pushing Medicare Advantage and so forth. So I would encourage you to be, as skeptical of that reporting and look at other sources of reporting that are more accurate. And I think that, veterans know and now are, as we said before, are very open, much more open, interestingly, to, expand and improve the VA message than pre-Trump. And so, my job is to try to think of what is our positive agenda? I want to make another thing clear, which is something, Marcy, that I discovered when I started working with veterans, is often if you mention the VA to veterans, and Hugh sort of hinted at this, if you talk about the VA stands for Department of Veterans Affairs, right? And the Department of Veterans Affairs runs the largest healthcare system in the country, Veterans Health Administration, largest benefit system in the country, the Veterans Benefit Administration, and the National Cemeteries Administration. And if you talk to veterans about VA and they start bad-mouthing VA, very often they're not talking about VHA, the health system, they're talking about the benefit system because they have difficulty, which is due to understaffing, of getting benefit claims processed. And I learned that the hard way because I thought, oh, wait a minute, I thought you guys liked the VHA and you're trashing the VA. And then it turns out, no, they actually love the VHA, but they don't like the VBA, because so I actually think, the majority of veterans, I mean, they have quibbles, and the system has problems. I mean, even if it was well funded and better funded, it would have problems because it's a human system. But I think I think when it functions well, which they're trying to destroy it because they don't like it delivers better care. I mean, I'm not kidding when I say I wish I could be cared for in the VHA. I mean, it's amazing. The people are amazing. They're very mission driven. They're not profit driven. And I just want to make another point that to the point Hugh made. Every big VA medical center is connected to a academic medical center, and every doctor who's in work, most of the doctors who work in the academic in the VA also have what do you call it? Like
Faculty
position.
appointments.
They have appointments in the
Yeah.
medical center,
Yeah.
but they practice completely differently in the VHA than they practice in the medical center because it's a different system
Right.
and it has different imperatives and it's mission driven. So
Right.
it's a mistake to suggest that the VA is the same as University of Washington or UCSF or something like that, because these doctors work in both places. When the doctors, and you can talk to many of the PNHP docs who work in the VA, and they'll tell you that. They function completely differently at UCSF than they function at Fort Miley. They have different imperatives, they have different, and they're fundamental, and they're mostly employed at the VA.
David, how we doing for
I don't know,
time?
Marcia, if I answered your question, or even if I
understand where you're coming from. You're trying to not fight against privatization of the Veterans Administration.
veteran,
So
yeah, the veterans.
you have a campaign, I guess, against that. Do you have a campaign? Your organization does? Can
Well, I mean, I'm a researcher and I have seen how the system works. And so, I mean, if it didn't work, I wouldn't be for it. If it was a shitty system, I wouldn't, I mean, I'm opposed to privatization of public services. Yes, my value is that I'm opposed to privatization of public services, but I'm both a journalist and a researcher, and I have seen that it works. And I've seen it.
I don't dispute that. I believe you. But I'm just wondering, the reason for this presentation tonight was to maybe enlist us in the fight to fight against privatization of the VA, or just to make us aware probably of what's coming down the road.
Well, I guess, I don't know, you'd have to ask Hugh and David what their goal was, but my goal was to, many people don't know much about the VA, and, I found that even healthcare reformers don't, and, I was actually wanting to share some of the information I found out about, private sector healthcare in the state of Washington, as well as nationally, which could be useful to folks fighting for broader healthcare reform. But also, yes, I mean, I think anybody who's a healthcare reform advocate should be fighting against the privatization of all public services.
for
Yeah, I
joining.
think it's more of the former and not as much of the latter, Marcia, to help people be more aware of the VA and at its best theoretically. And I think it has further deteriorated due to all of these funding impacts. And that's one of the goals of the Policy Institute, is to educate the public about the VA, what it was and what it still can be. But as long as the funding is continuously being eroded from underneath it, it has a hard time maintaining those standards. The other thing I would say, just from my perspective of having worked there as a resident and been on the faculty and having veterans in my family who I've talked to, a lot of these surveys of veterans, when you talk about veterans, these are veterans that are in the system that are benefiting from the system. The problem, I think, lies in the bigger set of veterans who aren't in the system or who have at some time touched the system, who are not as enamored with it. When you're in the system and it works, it's great. Ronnie, you had a question or comment?
I was just going to share a pharmacy perspective about the VA. The centralized refill system that the VA developed has been a role model for pharmacy for 50 years. It's something that people have adapted in a number of healthcare systems that has been really effective and has provided care that insurance companies pretend to give. So the VA has done that. And also to share that I'm now involved in genetics,
Oh, yeah, yeah.
pharmacogenetics, and the Million Veteran
I
Program
know, it's
is
amazing.
one of the largest banks of information called a biobank that the Veterans Administration has supported. And their pharmacy staff are leaders in that field. Uh, it's exciting to see the work coming out of the VA. It
Right.
grew out of cancer chemotherapy and the genetics that were needed for that, but it's advanced to helping improve mental health care, helping improve cardiovascular care, and
Right.
it's been really exciting for me to see that from my perspective over the years. So,
Ronnie, you are a clinical pharmacist, or what do you?
well, I worked for Hugh. I worked most of my career in public health. Spent a decade with Hugh at Harborview Medical Center. I'm now retired and have worked as a consultant with genetic company here.
But are you a pharmacist or?
I'm a pharmacist, so
Okay.
not a clinical pharmacist. I worked
I
talking
see.
to patients and providing care. It was a very satisfying career, and
Right. Okay.
we're
I just
always
wanted.
looking for ways to do things more efficiently. The VA system has been a
Right.
role model. And I think, Suzanne, one of the answers to questions like Marcia brings up is that the VA system publishes their wait lists.
Yeah.
They
Right.
publish the
Right.
things that don't work. We don't see that. The insurance companies don't do that.
Right.
The Center for Medicare Services
Right.
tries to do that, but they are
Right.
tied into all these Medicare Advantage programs that don't allow them. So we can see what the Veterans Administration can do is doing.
Well,
We
no,
can
I
see,
think you make a great point, Ronnie, and I should have said that to Marcia. You know, one of the reasons why we see the warts in the VA is because they are the most accountable healthcare system in the country. And, you know, all the things that go on in the VA that you hear reports of are going on in every other hospital in America, but you don't know about them. And in fact, you'll never know about them and you'll be unable to learn about them because even if there is a suit, right? It's, there's an NDA, right? And so I think, Ronnie, thank you for mentioning that. I mean, well, you used to have the OIGs, the Office of Inspector General before Trump. And, they've taken all the reports off. You have the media, you have Congress, I mean, it's just amazing that things you find out about the VA that you won't find out about anybody else because they won't tell you.
And Suzanne, your questions about what do we hear about single payer healthcare, we certainly get distorted perspectives on what's going on in Canada, that they are waiting in long lines. You know, the line you get it, the reality in the United States is, yes, there may be a long line for certain types of surgery, but in the United States, people don't have a line to even get into.
No,
It's
absolutely. No,
accessible.
absolutely.
We
No, I mean, that's,
criticize the the
Yeah,
United
I
Kingdom
would say
system.
that study, that state by state study that you did, that is shocking. Although I have experienced the wait times, and my patients have experienced them, and my friends have experienced them. Very, very, very long, months and months and months wait times for primary care, for pulmonary services, other subspecialty services. And there's this huge shortage of physicians. And I think Trump just said that he was gonna not allow people who are coming from foreign countries or something to get visas, or, I mean, they're just like wrecking the system further. And the reimbursements for I'm a family medicine doc, and the reimbursements for the family medicine and other primary care, including like OB, and I mean, it's just like really driving people away from providing good care. And I think the VA, um, especially the specialty care that's directed to people who have certain particular, a particular cohort that's very particular. And I mean, I had a patient who was in Vietnam who had exposure to Agent Orange, and I was his primary care doctor, but he also went to the VA for whatever screening and services he needed because of the Agent Orange, and he was very happy with that
right.
and very reliant on it. So anyway, I think your presentation, I thought, was extremely lucid and very, very interesting.
Thank you so much. I appreciate that.
I think a key point is that the providers within the VA system have an expertise that provide to take care of veterans, and particularly women that you just touched on briefly,
Yes, yeah.
compared to providers outside of the system. So, we ought to encourage and everything we can do to get veterans, seen within the VA system.
Yeah.
Yeah, and I think also when we fight for and whether it's national health care or Medicare for all or whatever we're fighting for, I I think we should be fighting for the former rather than the latter, but whatever. I think it's important to understand that I mean, as long as we have this imperial military and we have all these people who have suffered from these occupational injuries and problems, we will need within, I mean, if we could, if we could wave a magic wand, boy, I wish we could, I would wave it. I would do a lot of waving, but I'd be waving, I'd be, die from waving. But I think that we will have to have a VA system, occupational population health system within, whatever we get, if we ever get it. The VA is not going to disappear, nor should it, because, you have these people tragically who, been convinced to fight for their country, and they've, been screwed by the most recklessly unsafe, one of the most recklessly unsafe employers on the face of the earth, whether you call it the Department of Defense or Department of War. You know, these people have been screwed by it, and you have to take care of them, and you have to know how they've been screwed in order to take care of them.
There's also, I did some locum tenens at Air Force base. And I wonder, I don't know, I mean, that's a completely separate
Yeah.
entity, but I mean, I did see a lot of unusual things that you wouldn't see otherwise, basically. But also, I wonder how are those ever to be connected? I guess those are just for active duty people.
I mean, well, the military health system is a completely separate health system run by, the Department of Defense. And tragically, they've been privatizing it.
Oh,
And,
yeah.
and under Biden, they suddenly realized this is like a really bad idea, and they're not getting good care, and they're not getting, access to care, and it's impacting our force readiness. And they actually decided to sort of reverse the privatization. But then Trump got in, and they're probably reversing the reversal. And I mean, I'm not a big fan of the military, but it's quite interesting because, for example, and this is another thing, like what are they going to do if the VA disappears that they don't think about? But so the military health system does not do rehab because the idea is you get these people. I mean, they're not into chronic disease management because the idea is, that you get these people back. It's like football medicine, right? You want to get them playing on the football field. So they have an MOU with the VA to do all their rehab, and like their polytrauma centers are filled with active duty service members because they don't do polytrauma in the military health system. And actually, the military health system has an MOU with the VA that in time of terrorist attack, or if we had, a big war again, VA hospitals would supplement the military hospitals if they had an overflow. And I don't know if you're aware of it, but one of the things that the VA did during COVID was I mean, this is, what you have if you have a national health system, right? Because they have no financial incentive. They have global budgets, right? So they immediately canceled all elective procedures immediately, like right at the beginning of the pandemic, where hospitals, private sector hospitals across the street were running, total knees and stuff like that because it would cost them too much. The VA canceled it all, and they essentially pretty much emptied their ICUs to save their ICUs for private sector patients, if they were overwhelmed. Fortunately, they weren't in most places, but in New York, New Jersey, and Louisiana, for example, the hospital system that was overwhelmed with COVID patients, a lot of those patients went into the VA hospitals. And you could also, because these docs weren't on contract, they were employees, you could tell an orthopod, sorry, you're not doing total knees, you're going to do COVID testing. And they did. I mean, it's, it was pretty amazing.
I think the information you have shared with us has been very good and very expanded greatly our knowledge of what's going on in the VA. It brings back memories, of course. I did my psychiatric rotation as a medical student at Seattle's VA, so I remember it well, particularly the key that was this big and heavy that I had to carry to get in and out of it.
Yeah.
But anyway,
I roofed that building.
it's we want to thank you very much for
Yes.
coming and spending all of this time with us.
Yeah. Thanks, Suzanne.
Yeah.
Thank you so
Thank
much.
you
Thank
Yeah.
you.
so
You're
much.
so
Give my
kind. And
regards to Steve.
thank you. Yes. And I really appreciate being able to talk to you all. I'm going to put Ronnie, I would love to talk to you more. Anybody, but maybe David could connect us or you could connect us. But I would encourage you all, if you're interested, to sign up. I put it in the chat. The VHPI newsletter is free, and
Oh,
it has a lot of stuff that's interesting, I think, to folks that are, folks like you would find it of interest. And it's free.
Suzanne, you sent me 2 articles recently, and I will, when the report on this meeting in a couple days, I'll put those links in there.
Oh, thank you.
Also, this will be on our YouTube channel, so it'll be available, and people can buzz through there based on what topics.
Yeah, and
we're talking
I
about.
hope I answered people's questions, and I am a big fan of the VA, and I think I don't think we can afford to lose it, and I think those of us who really, I mean, my commitment to this work really has to do with wanting to see the kind of VA healthcare at its best be something for all of us. And so I think that, if they manage to kill a healthcare system for this very important sacralized group of Americans, we will have very little chance of getting healthcare reform. And so I think it's very important for all of us to connect the dots and be fighting for all these things at the same time, because it's all part of the same struggle.
Absolutely. With our
And I do
continuous-
think we have a great opportunity here. I really
Yeah.
do. I mean,
we need it more than ever with our continuous wars of the last 22 years.
yeah, but also Trump. I mean, he really is bringing,
Yeah.
he's bringing people in to, who we wouldn't have had a chance of talking to. I mean, I'm having conversations with people that would have shot me a year ago.
Yeah. No, I'm sure you have, as
So,
we all are. Thanks a
Okay.
lot,
Well,
Suzanne.
be
okay,
careful.
thank you so much. I so
You bet.
appreciate it. Thank you, Hugh. Thank you, David. And it was great to meet you all.
All righty.
Take care.
Okay.
Good night.
So, well, I'm
Oh,
going to close it
everybody.
off, and when I count to 0, 5, 4, 3, 2, 1, 0.